Welcome to Module 6 of the Health2Innovation program, Marketing in Healthcare. To better understand the dynamics of healthcare marketing, it's essential to first grasp how healthcare systems are structured across Europe, because depending on the country, the way care is financed and delivered can vary greatly, and that has a direct impact on how innovations are marketed and adopted. In Europe, we usually distinguish three main healthcare system models, each with its own logic, stakeholders, and financial flows. Let's take a closer look. National health systems, often referred to as Beveridge-type systems, take their name from William Beveridge, a British economist and social reformer whose 1942 report laid the foundations for the National Health Service, NHS, in the UK. This model of healthcare system is based on the principle of public funding, mainly through general taxation. In a Beveridge system, the government is both the main funder and provider of healthcare services, meaning that healthcare is generally available to all citizens without direct charge at the point of use. The key features of Beveridge healthcare systems are tax-financed. Health services are financed by tax revenues, making them accessible to the entire population, regardless of their individual financial means. Universal access. All residents of a country with a Beveridge system are entitled to healthcare, regardless of income, employment, or social status. Public ownership of infrastructure. Hospitals and clinics are generally state-owned, and healthcare professionals are often public employees. State regulation. The government controls not only the financing, but also the delivery of healthcare services, ensuring the quality and efficiency of the care provided. This model is designed to ensure equal access to healthcare and to minimise health disparities in the population. In addition to the UK, other countries such as Sweden, Spain, and Italy use variations of the Beveridge model. Social health insurance systems, also known as Bismarck-type systems, take their name from Otto von Bismarck, the German chancellor who introduced this model in Germany at the end of the 19th century. Unlike Beveridge-style national health systems, the Bismarck model is based on financing through health insurance contributions, usually compulsory, paid by employers and employees. Key features of Bismarck systems: compulsory health insurance. All citizens, or at least salaried workers, are obliged to contribute to a health insurance fund. These contributions are generally proportional to income, with contributions shared between employers and employees. Plurality of players. Health insurance funds are often multiple and can be public or private, but they are strongly regulated by the state to guarantee equitable access to healthcare. Benefits defined by law. The government defines a minimum set of benefits that health insurance funds must cover. This ensures that all policyholders benefit from basic coverage, regardless of the health insurance fund to which they are affiliated. Freedom of choice and competition. Policyholders often have a choice between different insurance companies, which introduces a degree of competition between companies to attract members while complying with strict regulations. Shared costs. Although healthcare is largely financed by insurance contributions, patients may be required to pay part of the costs in the form of co-payments or deductibles, but these costs are generally limited by law to remain affordable. Bismarck-type systems are designed to combine the efficiency of the private sector with the social guarantees offered by public regulation. They allow fairly broad access to healthcare while maintaining flexibility in the choice of providers and insurers. Countries such as Germany, France, the Netherlands, and Japan use healthcare systems inspired by the Bismarck model. Mixed healthcare systems combine elements of the two main models for financing and organizing healthcare: the Beveridge model, financed by general taxation and managed by the state, and the Bismarck model, financed by health insurance contributions with private sector involvement. Main features of mixed systems: dual financing. In a mixed system, healthcare can be financed by both general taxes and health insurance contributions. For example, some basic health services may be covered by the state via taxes, while others, such as specialized or supplementary care, are financed by private or social insurance. Plurality of providers. These systems include both public and private providers. Hospitals and clinics may be state-run or run by private for-profit or not-for-profit organizations, offering a diversity of care options. Regulation and state intervention. The state plays a regulatory role, setting standards and rules to ensure that all citizens have access to quality care, while allowing competition between public and private providers. Universal access with private components. Mixed systems aim to guarantee universal access to healthcare, while allowing those who wish or are able to do so to access additional services via private insurance. This may include supplementary insurance to cover costs not covered by the public system, such as dental care, optical care, or certain drugs. Flexibility and choice. Citizens can often choose between several insurance options or providers, offering a degree of freedom while guaranteeing basic coverage for all. Mixed systems seek to capitalize on the strengths of both models. They aim to combine the universality and equity of Beveridge systems with the efficiency and flexibility of Bismarck systems. This enables finer adaptation to local needs and contexts, while striving to maintain equitable access to healthcare for the entire population. Countries like Canada, Australia, and some European countries, such as the Netherlands and Switzerland, use mixed healthcare systems, where elements of both models are integrated to create a balanced and sustainable healthcare system. The marketing strategies to be applied in these healthcare systems differ due to their internal differences, so the strategy will need to be adapted to the system in question.